Wanted to introduce Dr. Streck is an assistant professor in psychiatry and medicine at Harvard Medical School, and she's associate director of addiction science research and programs in HPRIR. And she's a core member of the MGH Tobacco Research Center and the MGH Center for Addiction Medicine. She's a clinical psychologist who sees substance abuse disorders patients at the Bridge Clinic, and her research is funded by the National Institute of Health and focuses on identifying effective treatments for substance abuse disorders, including tobacco use disorder. Dr. Rachel Rosen is a clinical psychologist, and she's a research fellow at MGH and Harvard Medical School. She's also a core faculty member of HPRIR, and she provides support for the MGH Cancer Center's Smoke-Free Support Service and the MGH Tobacco Research and Treatment Center. She also oversees a training program within HPRIR, and her research focuses on developing and testing interventions to treat tobacco use among people with medical and psychiatric concerns. I want to hand over the presentation to them now, but for those of you who are just joined, this is HPRIR's Strategies to Manage Substance Use. Thank you so much.
Thank you, Elise, and thank you all for joining us tonight. As Elise mentioned, we're going to talk about different strategies to manage substance use. There we go. We'll start by talking a little bit more about what substance use is, including how to determine if substance use is problematic. The meat of our talk will be on evidence-based treatment strategies for treating substance use disorder, including medicines and counseling. And then we'll end and share some different resources for substance use treatment, both locally at MGH, as well as nationally. And we've left time for a Q&A, so if you have any questions that come up during the presentation, feel free to put them in the chat and we will have a discussion at the end. So when we use the term substance use, this can refer to a variety of different substances, including nicotine, alcohol, cannabis, or non-prescribed use of drugs like opioids or stimulants or other drugs. To quantify prevalence of substance use in the US, in 2024, 58% of those ages 12 and older reported use of tobacco products, vape nicotine, used alcohol, or other drugs in the past month. And there's a continuum of risk ranging from less to more problematic substance use. And we're often asked how to define when substance use becomes problematic. Especially people raise this question for substances that are widely available, you're able to purchase them. And one metric of defining problematic substance use is when one meets a clinical criteria for what's called a substance use disorder. And a substance use disorder, or SUD, arises when substance use causes clinically significant impairment or distress, and generally the time frame here is the past year. And we define impairment as when your substance use gets in the way of your routine day-to-day activities. So potentially substance use makes it hard for you to show up at your job, or it impairs your relationships. And this is manifested by having at least 2 symptoms from a list that I'll show you in a moment. And you can see in this graphic here below, whereas in the prior slide, we were looking at the prevalence of any substance use in the past 30 days. Here we're looking at the prevalence of having a substance use disorder in the US. And we can see that 17% of individuals in the US report living with a substance use disorder, a current substance use disorder. So a lower prevalence than those reporting any substance use, but still a sizable amount of the US population reporting a problematic substance use disorder. So in terms of the symptoms of substance use disorder, they're listed here. This is an exhaustive list. So an individual is potentially taking larger amounts of a substance than intended. They want to cut down on their substance use, but have trouble doing so. The third symptom is spending a lot of time obtaining or recovering from the effects of substance use. So one example of this could be having a hangover from drinking, craving or a strong desire to use. And then we see some of the impairment criteria listed here, like failure to fulfill major obligations at work or school or at home, continued use of substances despite problems, recurrent use of substances in situations when it's harmful. So this could be driving under the influence of alcohol or while intoxicated. And then the last 2 symptoms are tolerance and withdrawal, which are very important. Tolerance is when you need to use more of a substance to have the desired effect, or there are diminished effects of the substance with the same amount of use. And then withdrawal is something that people can experience when they stop using a substance. So this can be aversive side effects like anxiety or irritability or feeling shaky. And often people may take the substance to avoid withdrawal, which then perpetuates substance use. And all of these symptoms fall into generally 4 categories. So impaired control, social problems, risky use, and then finally the tolerance and withdrawal are housed under the physical symptoms of substance use disorder. And you'll note that I'm using the phrase substance use disorder, whereas historically you might have heard terms like substance abuse or alcoholic. And this is intentional. There's been a shift in the past decade in both research and clinical practice to use person-first language and avoid labeling, which blames or stigmatizes the patient for a condition. And so now substance use disorder is considered to be like any other chronic condition like diabetes or heart disease, where this is a condition that someone experiences that needs evidence-based treatment rather than a disease of volition or something that is the person's fault or to blame. And this is a table from the National Institute of Health, which sort of summarizes what I said, where in the left-hand column, we see the prior outdated stigmatizing term. In the second column, we see the recommended patient-centered language. And then this third column is explaining the rationale for why we want to change the language. So instead of addict, instead we'll use the phrasing person with a substance use disorder. Rather than user, you would say a person with addiction or opioid use disorder. And rather than a substance abuser, it might be a patient with substance use disorder, so on and so forth. So why treat substance use disorder? There's very compelling evidence, including recent evidence, which was summarized in a Surgeon General's advisory, that substance use, including tobacco and alcohol use, is causally linked to the development of cancer and various other adverse health outcomes, and it can lead to increased mortality. And we also know that substance use impacts people's quality of life. It worsens existing mental health symptoms, as well as physical symptoms like pain. And here we're focusing on how substance use can cause things like cancer, but it's also important to note that following a diagnosis of cancer, many people continue to use substances, and that's problematic because substance use following a cancer diagnosis is also associated with negative mental and physical health outcomes. It can worsen cancer treatment course and adherence to treatment, cause new tumors, further increase risk for mortality, and worsen quality of life. And often patients that we talk to have the misconception that once you have a cancer diagnosis or even a cardiac diagnosis, that the damage is sort of done and that at that point you might as well keep using substances since you can't improve your course. And that's actually a misconception and not true. There's much research and data showing that stopping or reducing substance use after a cancer diagnosis or other medical condition can improve your health outcomes and trajectory, as well as your cancer treatment course, and improve your quality of life. So it's never too late to quit or reduce your substance use disorder, even if you've already had a negative consequence from your substance use disorder. So generally, when we begin treatment for substance use disorder, which we'll talk about in a moment, we begin by understanding a patient's goals or motivation for changing their use. So everyone who uses substances may have different goals for their substance use. Some people may not want to change their use, nor view their substance use as a problem. Other people may want to reduce their use, but not completely eliminate use. And sometimes this is coined or termed harm reduction rather than cessation. And then finally, some people may want to completely stop their substance use, which is sometimes called complete abstinence or cessation. And there's evidence to suggest that people's goals change and motivation changes over time and even within a day. Now, despite this, the national and clinical recommendations for treating substance use make it clear that even though not everyone might want to change their substance use or might not be motivated to change, that we should still offer everyone who has problematic substance use evidence-based treatment and that they could benefit from this treatment. And this is in line with patient-centered models of care. We don't choose who we give treatment to and when we give treatment to and make assumptions, but rather, just like we treat cardiac disease, just like we treat any other chronic condition, we systematically should be offering everyone first-line evidence-based treatment. And this patient-centered model of care is presented here. So most healthcare systems, including Mass General and Mass General Brigham, are moving towards these recommended patient-centered models of care. So in addition to what I just mentioned, where we don't discriminate and we offer everyone evidence-based treatment, we also want to offer autonomy and respect their choice. So we might suggest someone goes to treatment, offer it, but they may not ultimately stay there or want to be there, and we would respect that decision. Other tenets of patient-centered care is to make sure that the treatment provided by a provider, doctor, healthcare system aligns with what the patient wants. To make sure that care is collaborative and accessible to everyone. To make sure we prioritize patients' physical comfort and emotional well-being, that we respect and include their family when they want their family included. And that importantly, we're very transparent in information delivery to patients. So now we'll talk a little bit more about specific treatment strategies for substance use disorder. And the first piece that we'll cover is evidence-based pharmacotherapy for substance use treatment. At the end of this presentation, we present specific resources for obtaining treatment, including medication. And anyone who has any questions about medicine or might be interested in medication treatment, we'd recommend that you talk to your primary care doctor, your psychiatrist, or another addiction medicine specialist. But today our goal is to emphasize that there are evidence-based medication treatments for addiction that are available and recommended. So medications are recommended first-line treatment for many substance use disorders like tobacco, opioids, and alcohol use. And sometimes it's recommended that you combine medication with counseling, like in the case of tobacco use disorder, alcohol use disorder. However, medicine is not available for all substance use disorders. So in the case of stimulant use disorder, there's no first-line recommended medication that's been found to be effective for stimulant use disorder. So this could stem, for example, from prescribed stimulants or from cocaine use disorder. So right now, the first-line treatment for stimulant use disorder is actually a behavioral treatment. So for opioid use disorder, there are highly efficacious treatments for opioid use disorder, which are listed here and include methadone, buprenorphine, and naltrexone. And I present this schema from the University of Kentucky, their opioid treatment initiative, where I think they nicely summarize all the ways that these medicines help with opioid use disorder, in addition to, or for example, helping with withdrawal, craving, and even pain management. There are also recommended pharmacotherapies for treating alcohol use, which we call alcohol use disorder, that are listed here. There are 3 FDA-approved treatments. And then finally, for tobacco use disorder, there are 3 categories of pharmacotherapies available for treating tobacco use disorder. And this can stem from cigarette smoking or cigar use. The first is nicotine replacement therapy. The second is varenicline, and the third is bupropion. And I've put an asterisk next to the 2, which are first-line recommended treatments where the research has shown the highest efficacy for promoting tobacco cessation. And those are combination nicotine replacement therapy, which is combining the patch with an intermittent form of NRT like the lozenge or gum, and then varenicline. And these medicines have been extensively tested for tobacco use, namely from cigarette smoking. There's also a lot of compelling data coming out looking at some of these medicines for promoting e-cigarette cessation. So one of those citations is below from Dr. Evans, who recently published a study looking at varenicline for helping treat youth and adolescent vaping or e-cigarette use, which is rising. So as mentioned, if you're interested in medication treatment for addiction, please contact your primary care doctor or any other psychiatrist or addiction medicine physician that you work with, and we'll present some specific local and national resources at the end of today's presentation. So I will turn it over to Rachel now, who will get into some of our evidence-based behavioral counseling skills for treating addiction.
Thanks so much. And really excited to talk about some of these behavioral counseling skills. And just a note that this is a little snippet of things that you might be able to think about or try from home, even outside of the context of formal treatment. Though if you were to seek treatment and receive behavioral counseling, it would be a more structured and comprehensive approach that we'll describe. So on the next slide, I'll first describe the sort of leading model for treating substance use disorders, which is cognitive behavioral therapy. And one of the underlying assumptions of cognitive behavioral therapy is that people's thoughts, emotions, and behaviors are related and impact each other. So the thoughts that we have might impact the way that we feel, and that might impact our behavior, which then in turn might again impact our thoughts and our emotions. And we have the ability to then intervene on any of these different kind of corners of this or points of this triangle. And I'll sort of walk through different ways that we might think about learning more about our own behavior and also targeting our behavior through thoughts, emotions, and other behaviors. So before we get into some specific skills, we wanted to first define some common terms that we'll continue to use throughout today's presentation. The first is if you can click again, is cravings or urges. And so on the surface, this might seem familiar to most people, the idea that a craving is a strong urge or a desire to use a substance. I want to also highlight that sometimes urges and cravings might show up in other ways. For example, an urge or a craving might show up as a thought, like I want to use X, Y, or Z substance, or I really want a cigarette right now, for example. It might show up as a mental image, thinking about or picturing yourself doing something or using a substance. And you also might notice a physical sensation. Sometimes this might be a tingling feeling in the throat, tightness in the chest, warmth in the stomach, things like that. The next term is a trigger. And a trigger is anything, for example, a person, a place, or a thing, a situation that has the potential to lead to substance use. And these can be both internal or external. Some examples of internal triggers might be things like emotions, like stress, or thoughts like we were describing above. Also sometimes physical sensations like pain. And they can also be external, like different places, a familiar bar or convenience store, other people that are associated with different substance use behavior, or even sometimes times of day or events that occur throughout the day, like meal times or having coffee, for example. The last term that we wanted to define is automatic thoughts. We think of thoughts as automatic to highlight that these thoughts or any thoughts that we might have can pop into our mind without awareness or without any choice, that these are thoughts that come up because we are people with minds that think. And so the thoughts that people have, we describe as automatic, not again, because there's anything that we're doing to have these thoughts, but because they might show up throughout our day. And often these are thoughts that are either unwanted, unhelpful, or sometimes related to substance use. So the first skill or piece of this skill that I wanted to talk about today is self-monitoring. We know that one of the most important steps toward changing any behavior is paying attention to it and knowing more about it. So I like to think of self-monitoring as paying attention on purpose, not recalling things that have necessarily happened in the past, but thinking about behavior and all of the things that lead up to a behavior and follow a behavior in as close to real time as possible. So I wanted to walk through two examples. The first is displayed here on the screen. And so just to orient everyone to what we have here, we have many different columns that each represent steps along the way from things that lead up to a behavior again, and then the things that follow. So we have triggering events, we have emotions and thoughts like I was describing on the previous slide, cravings and urges, the behavior itself, so the substance use specifically, quickly, and then some of the consequences. And these can be both positive and negative. So in this first example, just to walk through the person whose information is here, for example, they're describing a situation at 9 a.m. where they woke up and they're drinking coffee. So drinking that coffee is a trigger. It's a situation that is increasing the likelihood or potential for substance use. And at that moment, the person notes that they feel tired and maybe a little bit irritable, having just woken up and starting the day, maybe without having had any cigarettes through the night. And at that moment, they may have a thought like, I've got to have a cigarette to start my day. It's part of the routine. And notice a really strong craving or urge, about an 8 out of 10. Following this chain, the person reports smoking 1 cigarette and notices some immediate positive benefit. For example, feeling a little bit more relaxed, a little bit less irritable, and noticing some negative consequences that follow pretty quickly as well. For example, feeling a little bit upset or disappointed at the behavior of smoking because of a desire to quit or cut down. And so this is one example of how someone might track this. A second example might be someone, again, driving home after work and driving by a liquor store that's familiar and arriving home to make dinner. So there are kind of 2 situations or events that have happened. And they, again, notice some emotions and thoughts. So feeling, again, kind of tired after a long day and thinking it would be nice or relaxing to have a glass of wine while I cook dinner. And the craving at this point was a 5 out of 10, so not the most severe or strong urge, but also not nothing. And in response to this chain of events, this person reports drinking 4 glasses of wine over the course of the meal prep and the eating of a meal. And similarly, this person may notice that they felt some positive, they felt maybe a little relaxed and maybe fell asleep easily that night, but also some negative consequences, feeling disappointed about drinking in front of their kids and then noticing that their sleep was impaired in the later part of the night. So if you're somebody who wants to start paying attention on purpose to your behavior, one way you can do this is by creating your own little table like this, or taking any kinds of notes on any pieces of this chain in the notes section of your phone, on a piece of paper that you stick to the back of a cigarette pack or that you keep in your wallet. And again, this is really helpful for paying attention to the behavior that you want to learn more about and change. So I'll walk through some now of the steps along that chain of events and different ways we can intervene and try to stop the behavior from happening before we get there. So I'll describe a few different acronyms throughout the rest of these skills. The first is targeting triggers. So we have the ACE skill. And the A in the ACE skill stands for avoid. So in this situation, when we're trying to manage triggers, one thing we can do is try to avoid them altogether. If we have known triggers, like for example, if I know driving by the liquor store that I frequently go to is a trigger, I can try to find another route home if it's possible and if it's convenient, and I might be able to avoid that trigger altogether. Some triggers are a little bit harder to avoid, but sometimes we can change them. And by doing so, we can make the situation a little bit less risky. So for example, in that the first example we did on the last slide, drinking coffee at home may be one of the things that makes it more likely that I smoke a cigarette. And so instead, one thing that we might consider is taking the coffee on the road and leaving the cigarettes at home. So there's an ability to change the trigger so that coffee doesn't have to lead to using a cigarette. And then the last thing is setting up an exit plan or being able to use an exit plan when we couldn't avoid or change the situation or didn't anticipate it. So having an opportunity to signal to a friend, for example, if you're out somewhere, that it's time to leave, that you need to escape or leave the situation. And these are often most helpful when we can anticipate them and we can try to avoid them or change them in advance, and escape plans for when, again, we might encounter things unexpectedly or not expect them to be as intense or as strong of triggers as we initially thought. The next step is managing cravings. So maybe we avoid triggers as best we can, but sometimes we have cravings, which is common and expected when people are using substances. So one way that we can think about skills for managing cravings is using this additional acronym of the 4 Ds. The first D is to delay, to try to wait out a craving. So we know that cravings don't last forever. And during the midst of a craving, it may feel like it's lasting forever. But if we think of a craving like we think of a wave, we can try to surf or ride out that urge or that wave to make it through before we use a substance, to try to reduce the intensity or frequency of future cravings. So for example, if you notice that trigger and that craving, you might notice the cravings start to intensify, but just like a wave, it can't grow forever. It has to peak and then fall. And the same is true of craving. So sometimes that imagery can also be helpful to remind yourself that you might be able to delay until that craving decreases. The next D is to take a drink of something that is a non-alcoholic beverage, for example, water or some other desired drink, something just to kind of fulfill that desire or that craving that might be on your mouth. And keep you a little distracted. The next D is deep breathing. If this is new to you, one of the ways that I like to think about teaching really deep breathing that has the ability to really slow down our bodies and our minds is to imagine that you're blowing up a balloon or a beach ball in your belly. Really trying to direct that breath lower down into your abdomen as opposed to just noticing your shoulders kind of rising and falling. And deep breathing can be really helpful as well for managing stress, which is often a trigger for craving for folks. And then the last D is to distract yourself. So doing really anything else that can keep your mind off of drinking or smoking or any other substance use. And this might involve engaging in some sort of activity or other behavior, or reaching out to a friend or getting support from someone you know. There are other strategies for managing cravings as well that are based in mindfulness. So mindfulness, breathing, and grounding exercises. What I love about these exercises that I'll describe in just a moment is that they are free and accessible wherever you are without people knowing that you're doing them. So the very first one is a breathing exercise or like mini mindfulness exercise where you count down from 10 to 1 and you take a deep breath at each number. And this is one way to really, again, kind of slow down your system, slow down your mind, try to manage some stress. And this can be done, again, anywhere at any time. The second exercise is a grounding exercise that allows you to really stay present in the place or in the moment that you're in. And so this is the 5, 4, 3, 2, 1 skill, which allows you to use your 5 senses to, again, ground yourself in the moment and in the present. So thinking about or looking around to see 5 things around you, maybe touching 4 things around you or in your immediate vicinity, listening for 3 things you can hear, 2 things you can smell. Maybe there's a candle, or maybe there's food being prepared in another room. Maybe it's just the smell of your home. And 1 thing that you can taste, maybe something that you actually have in front of you, like a beverage, or maybe something that you consumed earlier in the day. And these are, again, skills that you can use anytime throughout the day, anywhere that you are. On the next slide, we're going to talk a little bit more about thoughts. So this is where these automatic thoughts are coming up that I was describing earlier on. And one thing that's really important is that thoughts are not facts. Thoughts are automatic thoughts that appear in our minds and they're not facts. Thoughts are oftentimes unhelpful or can be unhelpful, and they and we can do things to manage those. So one of the ways that we can, again, start to change the way that we think, if it would be helpful for us, is to pay attention and notice what our thoughts are. And we can pay attention to what we sometimes call thinking traps, these different traps that we might fall into with our thinking that can make it challenging to act or feel in a way that we want or that supports our goals. So I'll describe a few different thinking traps. The first is black and white thinking. This comes up when there's really kind of two polar opposite options and there's not really any gray area in the way that we're thinking. So I've completely failed at my treatment by drinking today. This would be an example of black and white thinking. And on the next slide, when we get there, we'll talk a little bit about how we might challenge or shape some of these thoughts to support our goals. The second is jumping to conclusions, making assumptions, and really trying to predict the future or assume that something that we don't actually know. So I've been smoking for 30 years. I'll never be able to stop smoking. And then the last one is should statements. I should have been able to get through the day without drinking. And these should statements often and almost always have the word should in them. And the way that we can try to remember or help ourselves to not fall into this trap of should statements is to remember the stop sign. Stop shitting on yourself. On the next slide, we'll talk a little bit more about how we can replace or challenge some of our unhelpful thoughts with thoughts that feel a little more helpful and that are more effective, meaning that they help us reach the goals that we have, which, as Dr. Streck highlighted, can be different from person to person. So we might ask ourselves what the evidence is that my automatic thought that I'm having is not true, or whether there's another way I might think about a situation, or maybe what I would tell a friend, a child, or a loved one in the situation that I'm in. So in the example of the black and white thought, I've completely failed treatment by drinking today, I might reframe this thought and replace it with the following. Today didn't go as I expected, but slips are normal and they happen and they're instructive. I can continue to make progress again starting now. I'm not starting from square one. The next thought, this example is I've been smoking for 30 years. I'll never be able to stop. And we might replace this thought with another more helpful thought. I've reduced from 10 to 5 cigarettes. I can reduce again and I can quit if I keep trying. And the last one, I should have been able to get through the day without drinking. We might replace with, today was stressful. Some days will be harder than others, and I can keep going. And I also want to highlight that sometimes we think that progress over time is really linear, that we'll continue to move up toward that top right corner. And if we haven't done that, we're failing, or we're starting over or starting from square one. And in fact, what we actually see is that progress looks a little bit more jagged, that we sometimes have days or moments that feel really positive or that are really aligned with our goals, and other moments that feel like a little slip back toward the behavior that I'm trying to change. But what you'll notice is that any of these slips, any of the moments where we're moving a little bit lower down in terms of our progress, we're never lower than where we started. And progress is going to continue to happen as we continue to put effort in and continue to get supported and access some of these kinds of skills and supports. The last thing that I wanted to share before we move on to some resources and other supports in the community is that one of the other things that we can sometimes start to do and that we sometimes can support continued efforts toward not using substances is to try to increase positive experiences that don't involve substances. And some examples that we include here are things like engaging in more enjoyed activities. And sometimes people notice that as they cut down or reduce substance use, some of these things become even more enjoyed than they might have been at other times. Social support or connecting with peers who are also making changes to their behavior or who are supportive of your goals, engaging in movement or eating foods that feel nourishing. And similarly, maybe noticing that the tastes and the smells associated with foods are improving or changing over time with reduced substance use. And also managing sleep. So these are also things that can target and address some of the added stress and some of the other added triggers that folks experience leading up to substance use as well. So now we'll present some resources for substance use treatment at MGH and then nationally with some links to learn more about some of these different resources. So first, we'll talk about MGH-specific substance use disorder treatment resources. The first is the SUD Bridge Clinic, which is a low-threshold treatment clinic for adults. And what's really important about this service is that folks can walk in, so you don't need an appointment if you're in need of more immediate support. And this service supports people at all stages of addiction, so it does not require that you're abstinent to access treatment, does not require that you have cut down or stopped any behavior yet. The next service is the West End Clinic, which is an adult outpatient treatment, more similar to a traditional outpatient psychiatry service where folks would come in for scheduled appointments, but with a specific focus on treating alcohol, substance use, and other disorders that commonly co-occur with substance use disorder. The Addiction Recovery Management Service is a similar kind of service, but serves children and adolescents between the ages of 14 and 26. And then the last MGH-specific service that we'll highlight for substance use disorder treatment is the Hope Clinic, which serves pregnant and postpartum people or folks who have young children. And this QR code brings you to a page with more information and ways to access support through any of these 4 clinics, as well as other substance use resources at MGH. In terms of state and national substance use disorder treatment resources, there are 2 websites that we'll highlight. The first is from the Substance Abuse and Mental Health Services Administration. And as you can see here on the screen, there are different kinds of pieces of information and treatment resources that you might be able to access, finding care or support for yourself or coping, how to pay for treatment, for example, if you need lower cost or free treatment, helping other people, and sometimes even getting immediate help. And the QR code here brings you to that website if you want to learn more about some of the resources through SAMHSA. The next website is the National Institute on Drug Abuse, and similarly, the screenshot here is of the website. So some questions that you might be asking that you might want to learn more about, like, are substance use disorders treatable? And hopefully Dr. Streck and I have convinced you that there is some support and that they are, but also help you find access to different kinds of treatments or to learn more about the different types of treatments, including things like mutual help groups like AA or NA and other things like that. And there's similarly a QR code here that will bring you to this page if you'd like to learn more about these resources. And then shifting gears again to some of our tobacco treatment resources. So while we've talked about tobacco and other substances in the same presentation, sometimes the treatments are offered in different kinds of settings. So that's why we have them separated here. But there are 2 specific resources that we wanted to highlight locally at MGH. The first is the MGH Smoke-Free Support Service, which is a service that supports people who are treated at the MGH cancer centers or who have been treated in the past. And this service offers free virtual one-on-one and group-based counseling. So the QR code on the top right corner brings you to the website for this service. And then the MGH also has an employee-specific program. So for any employees of Mass General who are seeking smoking cessation support for themselves or adult dependents, so they can access counseling through the information or the link and QR code on the bottom. And then in terms of state and national tobacco treatment resources, the Massachusetts State Quitline is one resource that offers free counseling and nicotine replacement therapy for people who live in Massachusetts, though there are quitlines if you live in other states. If you were to go to the link on the page here, there's an opportunity to personalize your program, so you can get support creating a quit plan and sign up for things like phone coaching or text coaching, as well as medication. And there's one more QR code here if you're interested in learning more about this particular resource. And at this point, I'll turn it back over to Dr. Streck for just one more piece of information on helping loved ones or supporting loved ones with substance use disorders.
Thank you. We also wanted to bring up one note and another topic that we're often asked about in the clinical settings that we work in, which is what to do if you have a loved one, a friend, or a family member in your life who you think has problematic substance use, and potentially that person may or may not want to change their use. Our main recommendation is to avoid confrontation or fighting with someone who is not interested in treatment. This can make the person defensive and less likely to seek treatment in the future. There are certain myths out there based on various television shows and things that have been publicized around interventions and confronting people when they don't want to or forcing them into treatment. And so we really recommend that instead you express your concern to your loved one. You provide evidence-based resources for treatment, and you leave it to the person to seek treatment or not. And ideally, the person would be open to your support, in which case you could help support them, for example, drive them to treatment if needed, or help provide resources. And in many of the clinics that Rachel just shared, providers will also consult with family members. And if you remember back to the patient-centered model of care, many patient-centered models of care honor and acknowledge the family's role and will include them in treatment. So that is all that we had for you today. Thank you so much for being here, and we're happy to answer any questions or discussion that may come up.
So thank you. I know that Annika had put a note in the chat if people had any questions to put them in the chat. Thank you both for this presentation. Do folks have any questions to put in the chat? All of the questions were answered.
Looks like someone's typing, so there might be a question arriving shortly. Oh.
They were just saying thanks. Okay, great. Well, thank you everybody for coming. We really appreciate it. Hope that this was, and I know this was an information-packed hour. Hope you found it yourself informative for what you were looking for. Please look for upcoming HPRIR webinars. And thank you so much, Drs. Rosen and Streck, for your wonderful presentations.
Thank you all.
Thank you.